Good afternoon. My name is Kyle Griffin, and I'm an athletic trainer with the University of Virginia Orthopedics Department. Today we'll be discussing my practicum, which involved orthopedic care for indigent patients, streamlining that process, as well as tobacco education. To begin this presentation, we'll begin by discussing the patient, John Doe. And John Doe is representative of a patient that I saw roughly 3 months into my working at UVA. John is representative of the problems that we address today. And as you'll see, John is a 70-year-old male. He has a history of smoking. He has end-stage glenohumeral arthritis, and his annual income is $20,000 a year. John arrived at our clinic in severe pain from his shoulder, and he needed to be seen. He drove from 3 hours away, and unfortunately, we had to turn John away from service at our clinic because he had not completed financial screening paperwork. Without this paperwork complete, John would not be able to pay for his visit. Because of this, John was forced to suffer for 3 additional months from his advanced stage shoulder arthritis. Eventually, he was able to come back to our clinic and be seen. He was given surgery, a shoulder replacement. And when he came back for his post-op visit, the results were not good. John's surgical intervention had failed. His wound was dehisced. And it was striking to me, so why were these things happening? So on our next slide, we'll go ahead and talk about the population that UVA is servicing. So at UVA as a whole, their outpatient clinics conduct 900,000 visits per year. These visits occur within a 50-mile radius of the UVA health system. You'll see on the picture there, that circle includes 11 counties that surround Charlottesville, Virginia. Of these counties, John is very representative of the indigent demographic. The poverty rate within these counties is 18%, which is much higher than 11.8, which is representative of Virginia as a whole. In addition, smoking rates are also much higher among these 11 counties. Smoking rate is 22%. So of the indigent patients that we are seeing, smoking is a big problem. And of those 900,000 outpatient visits that the university is seeing as a whole, many are indigent patients. So on the next slide, we'll talk about indigent guidelines. So John had a gross income of $20,000 per year. John fell within the 100% coverage for UVA's health system to have his visit completely paid for, but he neglected to fill out the financial screening paperwork. You'll see this chart illustrates, based on the household size, the cash allowance per year a family is allowed to make. So you see this increases by about $10,000 based on family size, and thus shows that a lot of patients are included within this financial screening guideline. So on the next slide, I'll talk about how do we address these problems. So first we'll start with indigent streamlining. First, I wanted to see how many patients were being turned away like John was. So I went to our front desk staff and I had them keep a logbook for the month of September to monitor how many patients per week came in without financial screening paperwork for their visits. In addition, during the month of September, I analyzed the financial screening system to determine where were the shortcomings. As I found, the shortcomings and the amount of patients that were showing up without financial screening paperwork went hand in hand. 40 patients per month showed up without complete paperwork and were turned away from service. In the financial screening system, they were not contacting these patients to inform them that they needed to fill out the paperwork prior to their visits or risk being turned away. Based upon this, I found it fitting to develop a phone tree that would contact patients prior to their visits and let them know these are the steps they need to take to fill out their financial screening paperwork so they can be seen at their appointment time. The success of this intervention will be measured pre and post based on the number of patients who were turned away after the phone tree intervention as compared to the number of patients, which 40 patients, that were turned away in September. As for tobacco education, there are currently no educational materials in our clinic for smoking patients. If a patient is smoking, we have no way of saying, do you want to quit? And these are the resources available to help you quit. As mentioned in John's case, his surgical intervention failed because he was a smoker. His wound was dehisced because of anaerobic deprivation of the skin, which is common among smokers. So these problems needed to be addressed. So first, I gained access to UVA tobacco cessation educational materials. Prior to placing these educational materials into the clinics, I found it fitting to educate our staff in the proper administration of these educational materials. So I conducted a 30-minute PowerPoint presentation prior to work one morning with all the clinical staff members. And they were required to go through this training and take a pre and post test to determine their level of knowledge. After this, the tobacco educational materials were placed into the clinic, and the success will be measured by the quit rate post-intervention as compared to the hospital quit rate. So next we'll discuss the results for the streamlining of indigent care. Post-phone tree intervention, if you'll look at the graph on the top right of the slide, you'll see that there's an 80% reduction in patients who were turned away post-phone tree intervention. Each data point is representative of 1 week within the month of September for pre-intervention and December for post-intervention. Data point represents the number of patients who were denied care at point of service due to incomplete financial screening, which there was a vast reduction after the phone tree intervention. 40 patients out of every 1,000 were turned away pre-intervention, while only 8 out of every 1,000 indigent patients were turned away post-intervention. And you'll see the bottom right graph is representative of these results over a year. With the phone screening system over year 2019, we'd expect to see that only 96 patients were turned away due to incomplete financial screening, whereas over the year 2018, potentially 240 patients were turned away due to incomplete financial screening. So this intervention was a success. Now next, we're going to discuss the results from the tobacco education intervention. First, we'll discuss the chart on the top right, which is representative of the educational class clinical staff is required to take. The first column is representative of the employees. There were 6 that were tested. The second column denotes the score that each employee had on the test prior to the PowerPoint presentation. And then you'll see the post-test score in the third column. Overall, the clinical staff increased their knowledge by 60%, while only 1 clinical staff member did not receive 100 on the post-test. After this was completed, we have now implemented tobacco cessation educational materials into each clinic room, and staff is well trained on helping patients who want to quit smoking. You'll see that we have a projected outlook of a 3% quit rate for January 2019, which will compare to the hospital quit rate of 7%. Unfortunately, we have no data that exists prior to January 2019 because our clinic did not implement tobacco education, so we can assume that there be a quit rate near 0 for our patients. So next, what do we see on our next slide? What's the future for both of these interventions? So for indigent streamlining, I'd like to continue the phone tree system for 6 months and monitor how many patients are being turned away each week. If it shows that there continues to be an 80% success rate for patients having completed financial screening paperwork at their appointment visits, I'll then attempt to expand this to other outpatient clinics. as mentioned before, there are 900,000 visits that happen each year. So orthopedics is a small fraction of that, but if we can replicate this across the other outpatient clinics, there will be less patients who are forced to go through undue suffering due to just complications with paperwork. As for tobacco cessation, I want to continue to monitor this in the coming months, and we want to meet or exceed the 7% quit rate exhibited by the UVA hospital. If we can achieve that, I think we'll be very successful and see lower failure rates among our patients as well as wound dehiscence. We'll also hold a meeting that will be annual each year or anytime we have an additional employee that comes on our team, so that they are also educated to apply the tobacco educational materials just like the other clinical staff members. So this concludes our presentation. I want to thank you all for your attentiveness, and we'll take questions at this time. Thank you.